My name's Mary Edwards, and I'm welcoming you to the, and on behalf of the Ask APSA committee, this is our session on overcoming barriers to pediatric surgical health care in North America. So the way we're going to do this is we don't have a lot of time, we have a lot to get through, but I'm going to start with a patient story, and then I'm going to turn this over to Kyle and Eric. We know that between the United States and Canada, there are some subtle differences with the problems with access to surgical care, and Kyle and Eric will sort of set the framework for that. And then we'll introduce our panel, and we'll talk about sort of ways that we can overcome these barriers, which I think is the point of the session. So without further ado.
Good morning. My name is Federico Seifert. I'm a pediatric surgeon and member of the APSA ASK committee. For the past 10 years, I've been working in underserved areas in Montana and West Virginia. I thank the panel for allowing me to share the patient story with you. Montana's vast landscapes and low population density pose significant challenges to delivering specialized health care. Despite telemedicine and in-person outreach by plane, many children still struggle to find timely access to care. Torrin's story is a powerful example of this ongoing issue. Torrin is a member of the Blackfeet Nation in the far northwest of Montana. The Blackfeet Indian Reservation is home for 17,000 members. It lies about 100 miles away from the closest pediatric hospital in Kalispell in the Flathead Valley. From birth, Torrin suffered from severest constipation. He has never seen a pediatrician or family practitioner. At the age of 9, he was referred from Browning's Blackfeet Community Hospital, run by the Indian Health Service, to pediatric gastroenterology in Kalispell. Colonoscopy revealed a partial obstructing friable exophytic mass of the rectosigmoid. Biopsies showed severe inflammation of metaplasia, raising concern for a malignancy. Subsequently, the adult surgical oncologist was consulted and a resection was planned. At this time, pediatric surgery became involved. Biopsies were reviewed and repeated. Finally, the diagnosis of Hirschsprung disease was established, and the child received a leveling colostomy and 6 months later a pull-through operation. Here you see a map with the Blackfeet Indian Reservation to the east of Kalispell. Between Browning, the capital of the reservation, and Kalispell, stretches the Bob Marshall Wilderness and Glacier Park, with Logan Pass being the only road connection. 9 years after his operation, I recorded this video last week with Torrin, who graciously agreed to share his story.
Hi, Torrin. Thank you so much for joining us and sharing your story. Tell us a little bit about yourself. Where did you grow up? Where are you now?
I'm in Browning, Montana, Blackfeet Reservation.
So, you remember I got to know you when you were a small boy, and I shared with the audience your diagnosis and your treatment. Can you tell us what you remember?
Thank you for joining us this morning and bringing pediatric surgery to children living in rural areas. Your work makes a difference.
It was hard. I'd always be stuck on the toilet for like hours because my parents and anyone like that was taking care of me would like think I was holding my poop in and all that. So I'd be on the toilet for a long time trying to poop, and I'd get so constipated that I'd be throwing up. Like my belly would get so big, I'd be throwing all that stuff up. And it was hard.
Were you able to go to school?
Yeah, but it was pretty difficult.
What about sports, friends? Did that have an impact?
I never got to play sports because of it. And I had not that many friends. I had like a few.
Got it. Tell us a little about your health care. Do you remember seeing a pediatrician or a doctor for that problem?
No, I never saw no pediatrician or doctor.
makes it. Do you remember, was it or is it an issue to reach the hospital from Browning?
It wasn't an issue for me. It was pretty easy. We had a car, but most people around where I live aren't so, lucky because most people don't have a transportation.
What about the ostomy supplies? So you had an ostomy for about half a year, and was it an issue to get these?
Oh, no. We got it in big boxes of all the stuff we needed.
How's your life changed? How's that operation, that treatment changed your life?
I feel a lot better. I could actually poop and live life instead of having to be like, distance myself and it's a lot better. Not so much like hurting and feeling like what's wrong with me.
You want to tell the audience about your family?
But yeah, I'm a dad. I got a baby girl that's a year old. I'm gonna graduate this year.
That is
the 18th.
awesome news. Congratulations, Torin. Torin, you have been great. Thank you so much for sharing this. We're facing challenges in rural areas, and we're working hard on trying to get specialized care to remote areas. And your story is a great example, or actually should say a sad example of a treatment that was delayed. But I'm thrilled that you finally got it. So thank you so much, Torin, and I'll stay in touch, okay?
Thank you for joining us this morning and bringing pediatric surgery to children living in remote areas. Your work makes a difference.
All right, at this point, I'm going to turn it over to Eric.
Well, good morning. Good morning, and belated welcome to Montreal for those who are here for our first time. And I just want to thank Mary and Torin for sharing such a powerful story that I really think starts us off in a meaningful way and gives us a framework for understanding what we're going to be talking about today. Have no conflicts of interest. And I would like to start us off in a good way and acknowledge with gratitude that we are gathered today on the traditional, ancestral, and unceded territories of the Kaniokihaka, or Mohawk First Nation, and the Haudenosaunee and Anishinaabe First Nations, who've stewarded these lands and waters since time immemorial. We're grateful for the opportunity to meet, share, and learn on these lands, and I pause for a moment of reflection on the historical truths of colonization that are foundational to our learning journeys towards reconciliation with all Indigenous peoples. Canada is the second largest country in the world with a population of 40 million people, of which 1 in 5 are under 19. We have a population density of 4 per square kilometer, which is one ninth that of the density of the United States, but 30 times the density of Greenland. We have 10 provinces and 3 territories, and our 3 largest cities, Toronto, Montreal, and Vancouver, account for 36% of the total population, of which 2/3 reside within 100 kilometers of the U.S. border. To put surgical access for Canadian children into context, it is helpful to understand the capacity of specialized child health services in Canada. We have 16 children's hospitals in 8 provinces, with no children's hospitals in our 2 smallest provinces, and 5 in Ontario, our largest province. Pediatric cardiac surgery, ECMO, and solid organ transplantation are regionalized services, meaning interprovincial transfer is necessary for access from some provinces. We have 8 training programs in the NRMP match, and our programs match and train Canadian, American, Middle Eastern, and low middle income country surgeons, mostly from Africa. Currently, we have 81 surgeons in active practice. This translates to 1 surgeon for every 100,000 children. Only 20% of Canadian children live within 100 kilometers of a children's hospital, and more than 50% of children under 19 receive their surgery outside of a children's hospital. We've known for the last 2 decades that demand for elective surgery in children's hospitals exceeds our national capacity, resulting in wait lists, that have been made worse by events like the pandemic. We now have at least 30,000 Canadian children who are waiting for surgery at Canadian children's hospitals and have no direct line of sight on the numbers who may be waiting for surgery in community hospitals. The graph on the right shows the gradually rising wait list in my hospital that is now over 3,600, with 2 out of 3 children waiting longer than national consensus wait time targets. If children who live in Canadian cities close to children's hospitals are waiting for surgery, it stands to reason that children in remote and marginalized communities, including Indigenous communities, face additional barriers to timely elective or urgent emergent care. Patient factors, particularly age, disease severity, and presence of comorbidities, will determine whether the child requires transport to a children's hospital or can be treated closer to home in a community hospital, provided there are some pediatric services, including general pediatricians and adult surgeons who are willing to treat children. Children who require the specialized services only available in children's hospitals require transport by fixed-wing aircraft, helicopter, or land ambulance. Weather is a frequent determinant of the mode of a transport, and inclement weather or limited availability of an infant transport team for a neonate can result in significant delays. These delays have consequences, including increased patient morbidity and mortality, but also economic hardship and isolation experienced by families who must leave their jobs and community supports to be with their child. Efforts to improve access for rural, remote, and Indigenous children will need to address barriers to care at children's hospitals and improve care closer to home opportunities for those children who can be appropriately assessed and safely treated in a community setting. Children's hospitals should adopt ethical frameworks for prioritization that considers rural and remote residents and Indigenous status as drivers of child health disparity and therefore adjusts their priority to ensure timely treatment. Travel and accommodation subsidies should be facilitated, and Indigenous families should be supported by Indigenous navigators and cared for by trauma-informed providers with cultural safety training. Efforts to improve access to care closer to home for patients for whom this is appropriate should include optimization of digital health strategies, including scheduled telehealth and on-demand consultation when feasible. Outreach services by pediatric surgeons and other providers from children's hospitals include remote site clinics for new and established patients and the possibility of outpatient surgery for selected patients. These outreach trips should leverage community partnerships that engage local providers, both surgeons and pediatricians, with lectures or CME. Pediatric surgery outreach is an underutilized access to care resource in Canada, currently available in 7 of 10 provinces, but provided in one form or another by only 8 of 16 children's hospitals. There are several models of outpatient surgery provided outside of children's hospitals, including a publicly funded urban pediatric surgery center and community hospital-based programs that include pediatric surgeons working with either community or pediatric anesthesiologists. More prevalent are the outreach clinics located close to a children's hospital to nearly 2,000 kilometers away in remote communities. The care teams travel the day before and will often combine an educational event with a clinic the following day or days. A way forward requires a health system that prioritizes children, and particularly those marginalized by rural remote residents and Indigenous and other racialized minority status. It includes a commitment to timely access for remote children requiring treatment at a children's hospital, and a future increased focus on providing care closer to home by a combination of incentivized adult surgical providers and pediatric surgeons. Thank you.
All right. Now we've heard about Canada. Kyle's going to tell us about the United States.
So, good morning. In the next few minutes, I'll briefly cover what we currently know regarding these 3 questions. First, where do U.S. children live in relation to specialized surgical care? Second, who provides surgical care for children in the United States? And does residence in a rural and/or remote area impact surgical outcomes? So first, I think it's important to review and differentiate these two terms that we're using. First, rural is an inexact term that refers primarily to population density and housing density. There are varying definitions for what constitutes a rural residence according to U.S. government agencies. But we do know that approximately 20% of the U.S. Pediatric population, which is about 12 million children, do live in rural areas. The term remote, on the other hand, refers more to geographic isolation and the distance necessary to reach some important resource, in this case, that resource being specialized surgical care. How far is too far, or what distance constitutes being remote, can be a point of debate. It likely varies by region, country, and certainly depends on a family's resource level. But oftentimes 60 miles has been used as a cutoff, as a measure of remoteness from care. So I think it's important, as we discussed, to note that some children live in rural areas, some children live in areas that are remote from surgical care, and some live in areas that are both rural and remote. So with regard to the distance between U.S. children and the pediatric surgeons most adept at caring for them, this study looked at the location of APSA members in relation to where children lived using 2010 census data. We found that approximately 10 million children, or about 15% of the pediatric population, lived more than 60 miles from the closest pediatric surgeon, and about 1/4 in total lived over 40 miles from the closest pediatric surgeon. So given this geographic imbalance between where children live and where pediatric surgeons are located, a large proportion of care, in particular, many of the most common and routine operations, are actually provided by general surgeons outside of major children's hospitals. For example, this study found that in North Carolina, general surgeons perform over 2/3 of cholecystectomies, about half of appendectomies and gastrostomy tube placements, 22% of umbilical hernia repairs, and 15% of inguinal hernia repairs. As you might expect, younger children and those getting more complex care are more likely to be cared for by a pediatric surgeon. Another study looking in detail at a common condition, specifically appendicitis in Wisconsin, compared where children lived in relation to where they had their appendectomy. And just 36% of appendectomies were performed in one of the two major children's hospitals marked by the green lines. Another 13% had their appendectomy in non-major children's hospitals marked in the blue lines, and the bulk, about 51% of appendectomies, were performed in non-children's hospitals marked with the purple lines by general surgeons. Those with simple as opposed to complex appendicitis, older children, and those living in rural areas and greater distances from children's hospitals were more likely to be cared for by general surgeons at non-children's hospitals. Although the data are sometimes hard to capture in other states, we do expect that most other states have similar trends to these seen in North Carolina and Wisconsin. So while community general surgeons have historically provided a lot of surgical care for children, that does seem to be shifting over time. As general surgeons seem to be becoming less likely to operate on children, and some rural hospitals are closing, and the total number of hospitals that are providing surgical care to children seems to be shrinking. These shifts have affected both urban and rural children, but have had a particularly profound impact on those living in rural areas, leading to considerably increased travel distance and transfers of care over time. For example, in two studies that used several state inpatient databases to look at shifting patterns of care from 2002 to 2017, the changes were quite dramatic, with travel distance for rural children increasing 102% for cholecystectomy, 88% for appendectomy, and 58% for inguinal hernia repairs. Similarly, transfers of care for rural children increased considerably. For example, 1% of children in 2003 were transferred for appendectomy, and in 2017 that had increased to 23%. Similar trends have been found for more urgent or time-sensitive conditions like ovarian or testicular torsion, conditions for which any delays in reaching definitive care might have a particularly detrimental effect. So if less surgical care for children is being provided by general surgeons in the community over time, what might be the reasons for these changes? A recent survey of over 160 non-pediatric fellowship-trained general surgeons in rural areas of North Carolina or North America provides some insight. So the most influential factors regarding their decisions whether or not to operate on children included their personal experience, expertise, and training, availability of a pediatric inpatient unit at their facility, and proximity to children's hospital and or pediatric surgeons nearby that they could transfer the children to. The factors that correlated with comfort in operating on younger patients were the amount and adequacy of their pediatric surgery exposure during their training, and a greater number of years in practice, meaning surgeons who had been in practice longer were more likely to feel comfortable operating on younger children. In addition, over 90% expressed interest in additional training during pediatric surgery during their pediatric surgery residency had it been available to them, which highlights some of the new training paradigms that are being proposed that increase rural surgeons' exposure to pediatric surgery during or after residency, which may enable them to provide routine surgical care to children and thereby minimize travel burden that's currently experienced by rural and remote children. So as we've seen thus far, where a child lives is certainly associated with where they get their surgical care and who provides that care, but how about the relationship between rural and remote residents and their actual outcomes? While the findings do vary, there's reasonable evidence for poorer outcomes. In pediatric general surgery, studies have found that children living in rural areas have increased rates of perforated appendicitis, negative appendectomy, and length of stay after appendectomy. In addition, greater travel distance, over 120 minutes of travel specifically, was associated with an increased odds of serious adverse events postoperatively in Washington State. And in Arkansas, a recent study found that children with greater travel distances, over 100 miles specifically, were also more likely to not complete their scheduled surgery clinic appointments. In adjacent fields like pediatric transplantation, greater distance from a transplant center has been associated with higher waitlist mortality prior to both kidney and liver transplantation, although graft outcomes are generally similar after the transplant. And in congenital cardiac surgery, greater travel has been associated with higher neonatal mortality and older age at surgical repair. But again, postoperative outcomes appear to be relatively similar. So in conclusion, we know that approximately 10 to 12 million children in the United States live in rural areas and or remote areas from pediatric surgical care. General surgeons in the community have historically provided a large volume of surgical care to children, especially common procedures like appendectomy and cholecystectomy. However, surgical care is increasingly shifting to pediatric surgeons and children's hospitals, and these changes have had a disproportionate impact on children who are living in rural and remote areas. And a number of studies have found that outcomes do appear to be impacted by a child's residence in a rural and or remote area. So the way forward as we seek to provide timely and efficient access to surgical care for children regardless of where they live, I believe requires an approach combining first targeted outreach, whether it be in person or via telehealth, into underserved areas for the specialized care that only pediatric surgeons can provide. Second, assistance for rural and remote families to ease the burden of traveling for specialized surgical care when that does become necessary. And third, partnering with community general surgeons, encouraging and enabling them to provide the surgical care that they're capable of providing closer to children's homes. Thank you.
Is this on? Okay. All right. Thank you, Eric, and thank you, Kyle. So it's obvious that there's a problem. We have three panelists here, Sid Johnson, Melanie Morris, and David Price, who are very unique and special and live and breathe this problem every single day. And what I think I'd like to do is to have them introduce themselves and talk about their issues with access to care, and then how they've used some of the various tools that have been mentioned to overcome this problem. And we'll open it up for discussion from the audience. So why don't we start with Sid?
Thanks, Mary. So yeah, I'm Sid Johnson. I've been in Honolulu for 20 years. Honolulu's an interesting place. There's 1.5 million people in Hawaii, a little over that, spread between 8 islands. 3 of them are the major population centers. Access can be, when you go to visit Hawaii, it's pretty straightforward. Flight between islands seems pretty nice. It's a little different when it comes to healthcare, in that you could argue that Hawaii is probably the place that has the closest thing to a single payer system. We do have the military system, we have a Kaiser system, but they're pretty enclosed with their own payers. And other than that, we have a single payer system, which does make some things pretty complicated, in that reimbursements are fairly low, and our ability to do things like transport patients is pretty convoluted. For example, it may take me an hour and a half to get to the Big Island from Oahu if I go on a commercial flight. Sometimes transport, because it requires EMS across the island, which might take a couple hours. The Big Island is actually big. And then they may go in an ambulance, then they may go in a helicopter, and then everything between the islands is fixed wing. And then they come to Oahu, then they have to go in another transport. So it's not unusual to have care from, Maui might be a 15-minute flight, and I'll routinely wait 8, 10, 15 hours, because having a single payer system, we have one helicopter system. There are times where we're trying to leverage the military system to be able to get children. A few months ago, I was at one of our outside hospitals on another island for administrative reasons. There was a child that had been sitting there with appendicitis for probably about 12 hours. My partner had accepted him. I walked by the ER, saw the kid, and said, I can just do this. And what we're seeing more and more is, as we've elevated our level of care, becoming a children verified surgical center, we have 4 capable general surgeons at that hospital, but this kid was 4. And they said, look, more and more, we can do the surgery. We even have an anesthesiologist that might be willing to do it. And I'm talking to the CEO of the hospital that I meet with all the time, and she's like, we know you can do the surgery here, but we don't have the actual care we understand we need to take care of the child. That kid didn't get his appendectomy for, I think it was about 18 hours after that, by the time we got the kid transported to Oahu and cared for. So we have a lot of problems with transport. We have a lot of problems with outreach. We've addressed some of it with, remote care. We were doing telehealth, well before COVID. That's been very helpful. For us, it was more helpful than, I used to fly out to outer islands and try to do clinics. Sometimes I would have 15 kids that would show up, largely chest wall, things that were non-emergent, stuff like that. Sometimes I would go to an outer island and I would just not really have anything. I would just sort of waste my day. It was very hard to predict what would show up in my clinic. I'd see a lot of hernias, but really the complex stuff that really needed urgent care, that was the difficulty. On top of that, we get random referrals from, or just people from islands you've never heard of. I mean, if you get on Zoom or Google Maps and you start zooming in, there will be islands that you've never heard of, and people will get on a plane and somehow end up on Oahu with really delayed care, dealing with a CPAM when they're an infant is one thing. Dealing with a 15-year-old that's had chronic infections for, 15 years becomes a totally different level of care. So when we get some of those complex things, another thing we've done is really work on, even when they're centralized on Oahu, really partnering with our adult surgeons to solve problems. I remember a case we had, I don't know, about 8 months ago, where we had a pediatric for a mediastinal tumor. We had it was actually a paraspinal tumor. We had a pediatric neurosurgeon, an adult neurosurgeon, a cardiac team from Stanford, my surgical team, all coming together to try and take care of a complex kid in Hawaii, because transferring, even though Stanford had seen, our cardiac team comes from Stanford, they'd seen the child, but for many reasons it was better to try and keep the care locally. And so we've done a lot of work trying to assemble teams for complex care in Hawaii to be able to keep the kids in Hawaii. We've had to do the same with ECMO, trying to figure out how to do inter-island transport, how to transport to mainland centers on ECMO, and essentially trying to just deal with this rural problem. I don't know if it's rural. Remote.
Kyle's Venn diagram.
And I guess I would say the best thing we've been able to do is really work on teamwork. Some of our problems, though, is as we elevate our care at the Children's Hospital, it actually intimidates some of the outer hospitals from doing routine care, because they realize it's not just the surgery, it's not just the anesthesia, it's actually the team care, the nursing care, and all the things that we emphasize are essential for the care of children. So it becomes a little paradoxical, and we're seeing more and more of our general surgeons are becoming less comfortable taking care of children. And we continue to say they should be cared for at the pediatric center. So I'll leave it at that.
Hello, my name is Melanie. I introduced myself in mid-shift. The language of the Métis people, one of the 3 recognized Indigenous populations in Canada. I just want to say thank you for having me today. I am one of the lonely 6 Indigenous surgeons in Canada. I'm the first Indigenous pediatric surgeon, which maybe last night we celebrated being first at the buffet. First as an Indigenous pediatric surgeon in 2025 is filling a void, really, and it's a lonely place at times. I want to start by thanking Eric for his land acknowledgement. I think I want to tell a little story about that, because he mentioned the Kanikehata nation here, the Mohawk people. They are a way to illustrate a little bit our relationship with our American colleagues, because the Mohawk iron workers, which live on Kanikehata, across from Montreal here, have a 140-year history of iron work. And these peoples constructed the Golden Gate Bridge, the Empire State Building, the San Francisco Bay Bridge, and the World Trade Center. And so when 9/11 occurred, they called the Mohawk ironworkers to ground zero, because they knew intimately the layout of the building and were able to help in an important and vital way for rescue efforts. And so I kind of use this to implore upon you that it is important to know the peoples of the lands that you work and play on. So I encourage all of you to be curious when you go home. Look up where you live and who were the people that were there, but more importantly, who are still there. And I am still here. And I am part of, like I said, one of the 3 distinct groups of Canada. So in Canada, there are the Inuit, the First Nations, and the Métis people. The Inuit live in the far north, so if we're talking about remote areas, we're talking about a people who reside in 53 communities in northern Canada that span 40% of the landmass and 73% of the coastline, but are more than whatever we described as remote, or most are flying communities. Most can't fly because of weather or climate. The First Nations, which exist across Canada and the U.S. In the U.S., there are 574 recognized tribes of Native Americans. We heard the story of the Blackfoot, the Blackfeet in Montana, the Blackfoot in Alberta, which are the same peoples. I'm from the Métis, which is from the Red River settlement in the prairies, but also span Minnesota and the Dakotas, and where a lot of my relations reside. So these geographic borders don't necessarily exist in some of our nations in Indigenous communities. The Métis, which emerged in the late 18th century, as a distinct cultural group and ethnic group. So we are a people that are significantly decreased in size and number by colonization, biologic warfare, ethnic cleansing, weaponized diseases, enslavement. And this is a story of Indigenous people that's not ancient. A lot of these things have occurred within the lifetimes of some of the people in this room. There were starvation experimentation done on children in the 40s and 50s. There were skin biopsies done on Inuit children within our lifetimes that took one piece of a skin from one Inuit child and put it on another just to see how grafting worked without permission. Within the last few years, I hear stories of women who have forced sterilization without permission. Indigenous women who die every day and girls who go missing. So my story is one to talk not about just the sad stories and the harms, but to celebrate Indigenous people, to recognize that they're present and that they're a large part of what's been described today in terms of remote communities, because they've been isolated or forcibly removed from their ancestral lands. But I also want to say that we want to be deliberate about care. We want to be thoughtful about care. And so trauma-informed care is important. It's important to know these stories because when that patient comes to you, it might be with mistrust because they're afraid you're going to take their child. And so when we talk about giving and accessing care for remote communities, I think it's important to understand not only the geographic barriers, but the socioeconomic ones too. And so as an Indigenous surgeon, my voice matters because, like I said, there aren't very many. In the US, however, there's actually quite a few, and there's even a Native American Surgeon Society, which I'm excited that maybe we can start to build some of that capacity in Canada. But I think liaising with your Indigenous patients, listening, knowing, and liaising with your Indigenous surgical partners will help inform that care so that racism doesn't persist when we talk about accessing care, when we talk about delivering care to surgical communities, that we as an institution don't accept the status quo with racism, and that we push towards equity, we push towards diversity, and we push towards delivering care to our kids that is informed, that is culturally safe, so that I don't remain the first and only, but the first of many. And I think that it also is important that when we look at reconciliation, it's about relations. It's about connecting with these communities to understand what they need and what they see as health and wellness. In my own world, I look at delivery of care in terms of advocacy, dismantling some of the systemic racism that exists in institutions across North America. I look at delivering care closer to home, but engaging with those communities, coming in and with humility and understanding that I may know my lived experience as a Métis person, but not as a First Nations or an Inuit person. That I may know the challenges that are faced by my community, but not those in some of our First Nations communities in the north. And when I think about my next steps, which is building surgical capacities in some of our remote communities, and looking at that perioperative care and the challenges we face with nursing, with beds, with hospitalization of our pediatric patients, I look at building those relationships so that when they do also come back to Winnipeg, they see somebody they recognize. And I want to build our healthcare force that it can reflect the population that we serve. Because in Winnipeg, 50 to 60% of patients at our children's hospital are Indigenous. And I think across Canada and the US, we see high proportions of Indigenous children. So my goal is to both deliver care to remote communities, but do it in a way that is respectful of my people and my Indigenous relations. Rich.
I'm David Price. I'm a pediatric surgeon in Newfoundland for the last 35 years. Putting things in perspective. Oh, how do I turn this on? Can you hear me? Yes. Newfoundland is a province of 150,000 square miles. There's one pediatric unit, or one pediatric surgical unit, right down in the bottom southeast corner. The province extends almost 1,000 miles north. If you look at it, the northern 100,000 square miles 20 years ago had no pediatrician, no pediatric surgeon. Currently, it has about 15% of the pediatric population. For a parent and a child to get from there to my hospital and a couple of days of hotel space costs $3,000. If we're talking about pediatric care involving consultation, involving another visit for surgery, involving follow-up, that means that many people cannot afford it. That's fine. We're talking about the northern 100,000 square miles. Only 50% of the children live within 100 miles. 20% more live 200 to 250 miles away. The next 20% live 350 to 500 miles. So regardless of what we say, we are remote. And when we talk about airfares, because many of these patients can only come by air because the road system doesn't exist for some parts, it's a big deal. Based on that, starting 20 years ago, we set up a traveling clinic system. You can call it a remote access, whatever you want to call it. And currently, we see 1,000 patients a year across 11 clinics spread throughout the hinterland. I made a presentation a little while ago, and when we only saw 600, that was saving the patients $980,000 that year. Having said that, it's all fine and dandy. You say, let's set something up. How do we set things like this up? How do we get it funded? Well, Newfoundland is Medicare, so it's the physician cost doesn't count, but the local hospitals have to. In Newfoundland, it was the Department of Health and Social Services. So if I went to a place and talked to the hospital, it was arranged by each remote place, we said, can you bring me there and I will see your patients? And they looked at it and said, well, if we save 2 Social Security or welfare patients going there, the costs of bringing this man here is evened out. And then the other 30, 50, or 100 patients who have to pay their own way don't have to pay their own way. And this, you just have to look and see how you do it. So this has been going on for a long time. There's a number of things that I think is very important when you're talking about remote care. And that's in at least 3 of those places, we have grand rounds or teaching rounds a couple of times a year. We also make a point of meeting local people. That means, 1, we can educate the local staff so they can do a lot more follow-up and patients don't have to keep going down south. 2, it means that we in the referral center get a better understanding of what's happening in the remote areas, and the people in the remote areas get a better understanding of us. And that means that we have much more balanced decisions about what needs to move and what doesn't need to move. In a couple of places, as time went on, we started doing lists of very minor cases when we went there. One of these was precipitated by a local surgeon who was extremely well trained, knew her anesthesia function, and when they were available for doing children of age 4, and she came to me and said, I haven't done a child's hernia for 10 years. Can I book a list and you hold my hand or help me while I'm doing it? And then we don't have to worry about sending the patients south. as you mentioned in Hawaii. And that makes a big difference. So my comments are, it's a matter of figuring out how to set up remote access, recognizing that it's needed, and it makes a big difference. The last thing I'd say, if you make remote access on an ad hoc basis, you don't get your trust. As you go back and forth there for the years, all of a sudden people from the most remote communities meet you in the airport. Thank God you're coming back. We have patience for you. Who might otherwise not have trusted this person coming in 10 years before. I'm going to leave it at that.
So I can't believe it, but we are almost out of time. Can we stay in the room and get questions and answers? Because the next session doesn't start till 9. Because I think this warrants some good discussion. I've heard some points I hadn't considered, especially the one about as we elevate the care at the children's hospitals and we sort of make that the standard of where children should go, that may make the problem worse for some of these remote populations due to cultural, economic, physical barriers, et cetera. That's sort of very intriguing to me, but that's just me. Any questions from the audience? Discussion? Just go ahead and step up to the mic and just introduce yourself, and don't be shy.
Hi, my name is Whitney Orji. I'm a PGY4 general surgery resident at UCLA. And I think similar to your question, I think even in like the adult sphere, we see that with regionalization of certain complex surgical procedures, you have patients who are, further and further away and have to extend more and more of their own resources in order to get to those specialized centers. But I know like the Kaiser system, for example, in Northern California, has programs where they, support patients either through like providing lodging and transportation, like subsidies and things like that in order to help support that. And I'm curious whether in Hawaii or in any of these other locations, if there are programs like that to support children and their families who have to travel these long distances. Thank you.
In Hawaii, it is, we do leverage the Ronald McDonald House. We have a few other ways I always pointed out, the better your insurance is, if you have the higher payer of our Blue Cross Blue Shield, the less likely they are to cover the family coming over. Whereas if you have, sort of almost self-pay, then they're more likely to cover the family. It's a little more supportive in an odd way. The native Hawaiians tend to be fairly trusting of the system in Hawaii. And as long as we can build it for them there, they tend to actually be very grateful and very happy to actually centralize their care. It's when we say, and I think it has to do with the socioeconomic factors. It's not that they distrust Stanford or Boston or something like that. It's moving the entire family for extreme complex care is very difficult. And so the more we can tell people we can build something here, we can partner with our adult colleagues or whatever and reach out. Peter, or I can't remember who it was in oncology yesterday, talked about how he gets second opinions from different members of APSA outreach talking about how to team things up. That is actually really helpful for our indigenous population because they very much want to stay in Hawaii, probably because they trust it. We have, for instance, a low immunization in Native Hawaiians because they don't trust the system. But the more, and I don't fit in as a local, oddly, but the more they get their care and they see that it's in our local system, they do trust that. But they don't tend to have a lot of trust outside of Hawaii. And so yeah, I don't know. I mean, we do have some of those things, but honestly, it becomes very difficult even to bring someone from an outer island. The socioeconomic impact is huge for those families. And most of them have 2 working parents, other kids at home. And as you all know, it really breaks families to have them getting complex care, even somewhat locally. So.
I have a question for Kyle and Eric. So I don't work at a place that trains pediatric surgeons, but we hear about telehealth, we hear about doing outreach clinics and working with general surgeons, but what about the general pediatric surgeon and pushing them farther out into the community? I hear that story that Federico said, and I just think if he wasn't in Kalispell, what would have happened to that child? I mean, he would have had to go to Utah. So thank God he was in Kalispell. And my question for the two of you is, do you think that this is, number one, something we should reconsider? And number two, do you think the current training of pediatric surgeons would support a practice like that?
I think it's we need to look at what I would say is our obligation in Canada to provide care for children in our provinces rather than having a mandate to care for children at children's hospitals. I think that's the traditional paradigm. It's the centers that we're trained in. It's the expertise that we come out with at the end. And so I think it would take a paradigm shift to kind of look at the responsibility of a surgeon with specialty training for children to be able to work in a children's hospital but have relational training, awareness of a lot of the things that we've talked today about in terms of cultural humility and the ability to go in and engage in communities with the communities at the level of the leaders of that community, which is very different from sort of the bureaucracy of a children's hospital. And so, we've heard yesterday about, the changes in our workforce that will need to accommodate people who come and go, need to take health leaves and things like that. And I think that a workforce strategy going forward is a bit of an oversupply of children's hospitals, with the acknowledgement that part of your responsibility in a children's hospital will be to do the hard work that you've heard described here today by two of my Canadian colleagues, of going out into the communities in the right way, helping to forge relationships and provide some care. We're not trying to create children's hospitals in the north, but we want to go into those communities in a way that allows us to reduce the burden of having disease away from a children's hospital. So I think a strategy in Canada might be that sort of view of workforce as being based at a children's hospital, but sufficient in number and capacity to be able to provide care outside of it.
I think most of our current pediatric surgery training programs are in full-service children's hospitals that are going to be very different if a graduate chooses a practice that's more in a rural or remote area. So I think one way forward may be some of these newer training programs where it's not a full-fledged pediatric fellowship, but it's more a general surgeon who does get some extra pediatric surgery training. So at least they're comfortable doing some of that basic routine surgical care that I talked about, and so at least those kids don't need to be transferred. And I think that may be a better training paradigm for many of the areas that need care as opposed to the full-fledged pediatric fellowship.
David Scarta, Salt Lake City. First of all, it's not so bad to go to Utah, by the way. Utah's pretty great. I just want to take a moment and just thank you for thinking about this, right? This is something that obviously in Salt Lake City we deal with all the time. And certainly we found some things that help us. I think at the same time, we continue to struggle with trying to figure out how to manage patients coming to us from 5 states. And I think this is a really complicated problem with a lot of internal conflicts and physician level and care level conflicts that we really don't have solutions for. And so I just want to take a moment and just express some appreciation for thinking about this and having this venue to discuss this, because it is something that we struggle with. Thank you.
Hi, I'm Eliana Gavar. I'm based in the United States, and sorry, my voice shakes, just ignore it. One of the questions I had, I worked in a place that was a children's floor in an adult hospital, and we didn't have some of the resources when you were talking about nursing being uncomfortable at a place once you had made a landing spot for children's more complex surgery. They were uncomfortable from like a nursing standpoint. And the other things that you get built in when you have a children's hospital, are there resources already out there that are kind of like packaged to help provide like, okay, we're not going to have a child life specialist where I was working, but that doesn't mean that there can't be ways, you know, especially with the internet, it can't be that hard. They have to exist. So I'm wondering if you know, and I'm sure I could have Googled it, but if you know, it'd be great to just share. If there's like hubs where people who are in these situations can go to look for resources, kind of like targeted to bridge a gap that exists. And if not, maybe we should kind of make one.
Yeah, I don't know of anything for like child life services, that sort of thing. I do think of, you know, like when you go out to a hospital that doesn't have the full set of like post-operative care pathways, that sort of thing. I've used oftentimes the APSA quality and safety toolkit to find like basic post-op, you know, post-pyloromyotomy pathway, those kind of things. Like you don't have to reinvent the wheel everywhere, and that at least has been helpful to me.
Mm-hmm. Yeah, I'm aware of those. Those are very helpful pathways. But yeah, just seeing if the other sorts of areas have something. It can't be that hard. I just didn't know if it existed already or if it's something to look into more on my own. Thank you.
We probably can do one more question before we really do need to leave because the next group's coming in.
Thanks so much, guys. My name's Olga. I'm the Pediatric Surgery Fellow in Halifax currently. The question that I had, sort of talking about pediatric training programs and general surgery, at least at our institution, we've certainly seen with CBME that there's been, you know, kind of a bit of a pulling away from learning pediatric surgery and sort of even the essential emergency surgical skills that one might need as an adult general surgeon. Even on the Royal College exam, I think I had 2 questions on mine related to pediatric surgical problems. And so in light of kind of that context and certain things becoming more focused to adult versus kids, I guess I'd be looking for any wisdom on how you recommend at least engaging with our pediatric surgical or our surgical, adult general surgical trainees about pediatric surgical problems and making sure that they stay engaged, and same with kind of general surgery residency programs as well. Thank you.
I'll speak to that from the Canadian context, and I think you're absolutely right that there's been a shift in training and sort of the foundations of what a graduating general surgeon needs in terms of their skills, and a de-emphasis of the importance of being able to look after children. And I think that that will take some consideration and conversation with the Royal College to sort of, particularly if we're moving to a situation where general surgeons, you know, are asked to be more engaged in the care of children. So it will take some changes in how training is conducted, and I think it also takes engagement, you know, and David spoke a bit about that too, when you go into these communities, of making sure you know who the surgeon is and they have your cell phone number and they can reach out to you, because I think it's also based on the relationships that we form in these communities.
So in the U.S., I can speak a little bit to the ACGME and the requirements, and you're absolutely right. There aren't a lot for pediatrics. There aren't. And we talk about pediatric surgical care being very subspecialized. Adult general surgical care is now very subspecialized too. And so to, I guess, make an average general surgery graduate comfortable taking care of pediatrics, I don't really see that happening unless they do additional training, or we somehow alter pediatric surgical training so that it's, you know, you'd be comfortable doing general care. That's my opinion, but I totally concur. We have to be very focused, I think, when we try to say the general surgeons are going to do this for us. That's going to take some effort. So with that, we really do have to leave. They're going to pull us off the stage. Thank you, everyone, and thanks to the panel. I appreciate it.